Hello, welcome everyone. Just so we can make sure that our audio is working properly over here, can you just let me know in the chat function if you can hear me okay?
Hello?
Great, I'm getting responses from folks that they can hear me. So I'm just going to share my screen and we're going to get started. So welcome everyone. If you're here today to listen to a webinar about what pharmacists should know about COVID-19. Oh, sorry. If folks could mute their line, I hear some typing and scratchy sounds in the background. Great. So if you're here today to listen to a webinar about what pharmacists should know about COVID-19, substance use, and safe supply, you're in the right place. We're going to be walking through the new provincial clinical guidance that was released here in April, as well as hear some more pharmacy nuance details and policy changes that will really affect you all as pharmacists. I'd also like to recognize that this is a co-organized webinar, so the BC Centre on Substance Use, as well as the British Columbia Pharmacy Association. So before we get started, just taking a moment to acknowledge the land in which we're working today is the traditional territory of the Coast Salish peoples, including the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh First Nation. Oh, sorry, I'm still hearing typing. Someone needs to mute their microphone. Great. And so also just to take a moment, if you are not situated in the Vancouver area, just to reflect on where you are in the province and recognizing on the land and waters. So a quick overview of our agenda today. We'll review some welcome and introductions, review the learning objectives, provide some background and context on how these guidelines came to be. We'll actually overview the guidelines themselves, review some OAT and COVID guidance, including bulletins released by the BCCSU. Then we have some time to review case studies, answer some of your questions, and have a bit of discussion about this. So before we get started, I want to introduce the amazing speakers we have for you today. We're pretty lucky for the pharmacists on the line. I'm sure these are no strangers to you, but allow me to introduce them. So Dr. Mona Kwong is the pharmacy advisor and director of the Addiction Pharmacy Fellowship at the BCCSU. She continues to practice pharmacy as a clinical pharmacist at the Infinity Medical Specialist Clinic and as a pharmacy manager and owner at the House Street Pharmacy. Dr. Kwong is an experienced instructor, mentor, and preceptor, and has shaped the minds and careers of many pharmacy students as a clinical instructor and preceptor with BC's new PharmD program. Sorry, can someone mute their line? There's a lot of typing in the background. All panelists, mute your line, please. Great. And then we have Ann Johnson. So Miss Johnson is a community pharmacist by training and is now the manager of pharmacy practice support at the BC Pharmacy Association, a not-for-profit organization that supports and advocates for the pharmacy profession in the province. Her role with the association includes developing and implementing training and education for community pharmacists and pharmacy technicians on OAT. Last but certainly not least, we have the amazing Guy Felicella on the line. So Mr. Felicella is a passionate advocate for the vulnerable people who suffer an addiction. He spent nearly his entire life suffering from the same disease, and now he educates communities on harm reduction through public speaking to eliminate the stigma that exists around it. Guy is a peer clinical advisor with the BCCSU and has started a career with Vancouver Coastal Health and the Ministry of Mental Health and Addictions, in addition to attending various school districts to educate students on addiction. So this is Amanda Giesler as well. So I'll be your moderator today, and I'm with the BC Centre on Substance Use, and we'll get right into our presentation. So I'll invite Dr. Mona Kwong to kick it off for us today.
Okay, thanks everybody. Thanks for coming in. So the learning objectives really simply at the end of the session, I'm going to speak a little bit faster sometimes, but the slide deck will be available for you to have a listen through. Describe key strategies for risk mitigation during the dual public health emergencies. Also recognize some of the appropriate pharmacological interventions based on evidence, as well as individual patient needs, circumstances, and preferences. I'll go through a little bit of what the prescribers are thinking as well. Appreciate the complexity of substance use disorders, diversity of care, and also provide informed referrals to evidence-based support services when appropriate. Be aware of the provincial temporary authorizations for OAT prescriptions, which you've heard about, to ensure continued access to medications. And of course, employ strategies to facilitate continued access to medications in the context of the current crisis, COVID-19, and develop a contingency plan for patients. So just a quick overview. As you know, in March 11th, 2020, basically COVID-19 is a pandemic, and BC declared a public health emergency on the 17th of March. What this means is that we actually have two public health emergencies in British Columbia. With the COVID-19, we're looking at social distancing, which means that there could be reduced hours operations at the pharmacy. For some pharmacies, we've closed a bit earlier to catch up on work. And also with the prescribers, clinic services can also decrease to meet the needs of patients. So there could be a little bit of disruptions in the drug supply for people who use drugs from the street. And the aim really is to employ strategies to ensure a safe access to substances to reduce the risk of harms and death that can be associated with destabilization or withdrawals. So there has been an increase of overdose deaths right now. So I'm going to go over really an overview of BC's safe supply guidelines, which is really how to prescribe safely in the context of the pandemic. There are new guidelines. So these are guidelines that were developed in partnership with the BC provincial government and many health systems reviewers, including regulatory colleges for the nurses, prescribers or physicians, and pharmacists. There is an updated version to include some cases as well. So really, we're here to look over this guideline, how to manage withdrawal cravings and other harms from opioids, stimulants, illicit benzos, tobacco, and alcohol. So really to support patients to self-isolate or maintain the physical distance and to avoid substance-related harm. This is not a substance use treatment, so that you folks know. This is a means to support individuals who are using out there within the context of the dual public health emergency. So these are just some names. Originally, this was developed in the Vancouver Coastal Health Region, and then things got adopted into the provincial guideline right now. So there is another guideline, the OAT guidance document that we've also looked into for the COVID-19. And basically, we, as pharmacists, it's a separate guideline for prescribers also to manage carries, dosing, delivery, etc. So if you guys are interested in joining our mailing list, you can email Amanda and our team a little bit later on, and we can ensure that you're on our mailing list. The goal is really similar, is really to support existing or new medications and also to self-isolate or maintain physical distance. This is a substance use treatment, and then you talk to your patients, as I'm sure we're all talking to them right now, in terms of a contingency plan in the event that they can't come in for medications or appointments. So a lot of us have actually, increased the prescription durations in consultation with the prescribers as well. And some of us are going out for deliveries. Now, the interim guidance was developed rapidly to provide clinical guidance in the context of this COVID-19 pandemic. So it does not provide a review of the relevant literature, but instead, because of how important and how fast things are moving, it really relies on the clinical judgment of prescribers when utilizing this guidance document. And this is a picture of how we usually develop guidelines, but again, this interim guidance document was developed rapidly to provide some clinical guidance. So it's important to know that in terms of eligibility, not everybody is eligible, but when you look at the 3 eligibility criteria, it does encompass quite a lot of people. And please note that youth and people who are pregnant may also be eligible for these services. And everybody who's at risk of COVID-19 infection, that's a criteria, confirmed COVID-19 positive or even a suspected case. There is also potentially a history of ongoing active substance use because, there's a lot of substances are not current. It's very hard getting certain substances on the market right now. So this includes opioid stimulants, alcohol, benzos, and tobacco. And of course, at a high risk of withdrawal, overdose, craving, or other harms related to drug use. So how did we develop this? Really looking at the literature and our clinical experience in IOAT, which I'll go through a little bit about, TIOAT, which is a tablet injectable opiate agonist therapy, managed alcohol program, which I will go over briefly as well, nicotine replacement, and also there's some unpublished research from Vancouver that also shows illicit hydromorphone use does decrease illicit fentanyl use. And across the Canada, there are other groups also looking at TIOT programs, for example. So IOAT, just a little quick context, was originally giving heroin in illicit heroin context. It's well studied. It does reduce illicit drug use, really good retention to care, reduction in sex work, and improve health and social functioning. So this was a program that was put into place in Vancouver a few years ago. There is a TIOAT program. This is a tablet IOT program. So T meaning it's a dilaudid. 14 months of clinical experience and chart review right now in Vancouver. No overdoses in 60 people on this program. And overdose was definitely one of the recruitment strategies in this particular program. And there is a lot of engagement in primary as well as chronic disease management within the teams. Of course, there is a titration of some of the opiate agonist treatment therapies. Adverse events that have been tagged are cellulitis and a few other things in a person who had an ongoing stimulant IV drug use. So with OAT and safe supply, so what is it? So just like IOAT and just like TIOAT or TIO, you can add on a safe supply in addition to any opiate agonist therapy that a person may be on. And how the clinicians look at this is both nurse practitioners and prescribers, they're really considering how much they're using on top of their regular OAT medications. In the assessment process, how much money are they spending on illicit drugs? And there is some review of the urine drug tests, of course, and then also there is a titration of the OAT as per other guidelines. So there is unpublished literature, like I said before, that using illicit hydromorph does decrease the amount of illicit fentanyl a person uses. That's why in some of the guideline work, you actually see the use of dilaudid. What is managed alcohol? We are not, as pharmacists, as familiar with managed alcohol unless we're working in certain places or within a hospital setting, within certain health authorities and hospital settings. So really, it's replacing an illicit non-beverage alcohol with a beverage alcohol. So these beverage alcohols are on formulary and then gets noted down within the hospital system. There are also managed alcohol programs in the community as well. So there's periods of abstinence that might occur, improve relationships, there's more connection with community primary care. So this is something that is coming in terms of some of the alcohol use disorder guidelines in the future. Of course, we're very familiar with nicotine replacement, well established, replacing a harmful substance with the same substance, just a safer mechanism to help nicotine replacement. So in terms of pain, like some people are wondering, well, what about pain? When the prescribers and the clinicians look at pain, they also assess pain versus opioid use disorder and look at urine testing, look at overdose history, etc. And really put that in the picture when a patient is being looked at. So you might have questions about your own patients when they come into the pharmacy. So this is a really good slide to perhaps print this out for you. So the medications used is in terms of opioids, you will see hydromorphone or daily 8s that are prescribed and that a person might present it along with an OAT prescription. You might also see a long-acting morphine such as MS1. With the benzos, you will see some scripts, but the goal is after certain things in terms of the pandemic might be over, then what will end up happening is the prescribers will look at this a little bit more closely, and the goal usually is to decrease its use over time. You will see some increase in stimulants depending if the person is using crystal meth. So you'll see some scripts for dexedrine or perhaps the immediate acting methylphenidates. And of course, alcohol and tobacco, pretty much you're used to seeing naltrexone, a camprosate that's still not available as of yet, and you might see some seizure medications or alcohol withdrawal, which we're very familiar with. And again, on the managed alcohol programs, when available, the person would be connected with the programs there. So this is an example prescription. When you look at the guidance document, and you can go online to our website, and you can actually download the interim guidance document. And these are example prescriptions here. So for example, we just literally saw one today at our store right now. So we saw the hydromorph 8 milligrams, 1 to 3 tablets, Q1 hour, PO as needed, up to 14 times 8 tablets a day. And it is daily dispensed, well, for our individual as well. And the prescription can be written up to about 23 days so that the person can potentially not attend clinic as much and also have a safe supply to consume if needed. Right now, this one says daily dispense, and the one to the right is a methylphenidate prescription and also says daily dispense. But again, depending on the assessment of the patient, the prescriber might write a certain number of carries during the script. So right now I'll turn it over to Guy to speak a little bit more about what's being done to access safer drugs now.
Hi everybody, thanks for having me. It's been a great week of webinars, and we hope that that the information that you're receiving today will help you as you move further on. Obviously, we're in an unprecedented times with 2 public health emergencies, and it's quite apparent and obvious that the old way of doing things is no longer working. And these guidelines actually are not radical by any means. They're just sensible for people to have the ability to practice that physical distancing that they actually need. And so the great thing that you know, this is a medicalized version of safe supplies. So it's the legal avenue that any doctor can actually do and any pharmacist can actually prescribe. And so here was, this is a document created by BC drug war survivors just on the easy, digestible, and simplified version of safe supply. Who's eligible, who can prescribe, what are some options, how will it work, and report any issues. The great thing that's with the rigid rules of opioid use disorder are now gone, so to say, so that people have the ability to actually get their prescription once a day and go home and be able to practice that physical distancing. Obviously, the challenges that we have is that you know, not all doctors we're trying to, you know, understand that they've been in this system for so long where they were told not to do this, and now in 2 weeks that these new guidelines allow them to do this. So if you have somebody that's struggling with substance use and active addiction, they're at risk for overdose death, but they're not only at risk for overdose death, but they're also at risk for COVID transmission. And that puts the patient at high risk, but also the general public at high risk. So it's very important to understand that when even people, and now the great thing with pharmacists is that you could actually be an advocate for people that actually come to your facility, or you get to know them If you knew Tom was not feeling well one day and he didn't have a prescription, the new guidelines allow you to possibly call his doctor, set up a telehealth so that he can get a prescription. And then the prescription can be a verbal order from the doctor over the phone and allow you to prescribe. So these guidelines are really in place to support people. And that's been the biggest change that I've seen, is that instead of, if trauma is one of the major factors of substance use and addiction, then why would we impact more trauma on people's lives? People are already struggling. So hopefully with these new guidelines that we can all get on board and move forward, because the slogan for COVID-19 should be the same slogan for the overdose crisis. We're all in this together, and we need to really help each other to get through it. And I do believe, and I've always believed, that when we do all work together, change is possible. Thanks for listening.
Thanks, Guy, so much. And I love how you can share all your thoughts and stories, for sure. So how does prescribing work? Like what Guy said, sometimes we have to work with the client's existing or assigned GP or NP who can use the protocols. And then we do our usual pharmacy delivery processes. It could be the person coming in, picking up. It could be the patient, a home visitation with a patient where it's a once a week drop off. And I'll go through some of the pictures that I'll show you about social distancing. And sometimes, guys, right, we have to advocate, because sometimes the GP might not have heard of this guidance document, interim guidance document as of yet, because it happens so fast. For patients that don't have a GP or NP, or if they've declined it because it's so new, there are links to the next slide, which I'll provide for you to connect the person further. And we have linked, for example, there was one of our patients, actually she just wasn't one of our patients, she came in and she needed help through one of our other patients, and we linked her with RAC, which is over at St. Paul's. Medication costs are covered by PharmaCare, and initial prescriptions usually are written for about 23 days, just to support isolation if something happens, but hopefully not. But if something happens, sometimes a person needs to be absolutely isolated for 14 days or more. So information for those without a GP. So there are OAT clinics accepting new patients. And generally speaking, the OAT clinics are quite well versed in terms of the guidelines. And FNHA, or First Nations Health, they've actually confirmed that they'll continue to provide and reimburse private OAT clinic fees. It's really important that this is being extended past the March 31st deadline that they were re-looking at the situation. There's also a searchable general list of GPs accepting new patients, but however, generally patients do know who is more well versed with OAT therapies. So what I'll do now is I'm going to pass on to Ann Johnson to go over some of the Health Canada exemptions to the Controlled Drugs and Substances Act and how it relates to BC College of Pharmacists of BC.
Great, thanks, Mona. Yes, I get the exciting part talking about the regulations. We do get a lot of questions about this because I know things are moving so fast. So like Mona mentioned, Health Canada has issued subsection 56 exemption from on the CDSA, the Controlled Drug and Substance Act, on March 19th. And this is really just to ensure that pharmacies can continue to provide such medications and that patients can still get access to these patients during the crisis. So you can see on this slide that there are the 4 exemptions that Health Canada has allowed, and of course it's up to the different jurisdictions whether they implement them or not. Our college has adopted most of these exemptions, and I will clarify in the next few slides what pharmacists in BC here can and cannot do. You can see here Health Canada exemption includes pharmacies to extend a prescription. It permits pharmacies to transfer prescriptions to another pharmacy, permits prescribers to issue a verbal order over the phone to extend or refill a prescription, and also allows pharmacy employees to deliver prescriptions of controlled substances to a patient's home or other locations where they may be, in other words, where they're self-isolating. Bear in mind that these exemptions are short-term, so they are at the moment set to expire September 30th this year, unless Health Canada or our college notifies us otherwise. So Our college board looked at these Health Canada exemptions, and then on March 26th, they approved amendments to our provincial regulations to allow most of these exemptions to be implemented. And I'll go into each one a little bit more, but here you can see the table that summarizes the temporary authorizations, what we are allowed to do here in BC until the end of September. So here we can accept verbal authorizations for controlled drugs from the prescriber. We can accept fax controlled prescription forms, and pharmacists can transfer prescriptions for controlled drugs to another pharmacy. Delivery of controlled drugs is allowed by pharmacy employees, and just earlier this week, this now also includes opioid agonist treatments to be delivered by non-pharmacists directly to the patient. I do want to add that pharmacists cannot adapt prescriptions for narcotics, controlled drugs, and targeted substances. I know there's been confusion by the word, what does extend mean? Some people think that extend means renew, but here in British Columbia, pharmacists cannot renew prescriptions. Our professional practice policy 58 on medication management has not changed. It has not been amended. So when it comes to adaptations, do not use the Pharmacare Intervention Code NL, renewal of prescriptions. I do want to add though that pharmacists, we can use our existing scope of practice and provide emergency supplies for any drug, and that does include narcotics and controlled drugs from continuity of patient care. And just make sure that you follow the principles outlined in our professional practice policy 31 when you're doing this. Okay, so for verbal orders, like I said, our POTSA bylaw was amended to allow pharmacists to accept verbal prescriptions. So this aligns with Health Canada's exemption. So the verbal order must come from the prescriber, and it can be for new prescriptions or when they issue refills for existing prescriptions. Okay, so really it should be between this communication should be between the practitioner and the pharmacist. The pharmacy tech cannot take the order, and really the MOA shouldn't be giving that order. It should be directly between the practitioner and the pharmacist. Just ensure that all the requirements of a prescription are written, like the date, the patient name, and also include your signature, the name of the practitioner giving the verbal order, and also their college ID number. And the last point there is the original CPP is required. So when you get that, make sure you attach it to your verbal order. And I do want to highlight there has been education and messaging to prescribers this week to make sure that they do send you that original CPP as soon as reasonably possible. We do get a lot of questions about patient signatures on CPPs, the prescription, as well as the OAT accountability log. Patient signatures are still required, and we should take all precautions to try and get that signature. And I know Mona's going to talk about that a little later on. But as I know, the college, the ministry are aware that this is not always possible, and they are looking into this. Okay, so our bylaws was also amended to allow fax prescriptions to be accepted during a declared public health emergency. Again, the original CPP, the original prescription, must be received as soon as reasonably possible. And so, we are now beginning to see an increased number or relying on like verbal or fax prescriptions during this pandemic. So it's really important as pharmacy teams to be extra vigilant and ensure when the prescriptions are coming through via fax that they're not forged and they comply with the prescription requirements. So this means that the prescription has to be faxed from the physician's office and by a patient, and it does have their office fax number and telephone number on there, as well as like the unique wet signatures of the prescriber and all the other requirements that a prescription should have. Again, a bylaw has been amended to allow the transfer of prescriptions for a controlled drug and substance within the same province. So it doesn't allow transfer of such prescriptions across the province or territories. And the bylaws do not specify that the original prescription is required by the pharmacy requesting that transfer. Okay, so our college implemented the Health Canada exemption to allow pharmacy employees to deliver controlled substances to a patient. The pharmacy employee who is delivering that medication on behalf of the pharmacist must deliver the medication directly to the patient or person responsible for the patient's care. bearing in mind that for oat specifically, it must be directly delivered to the patient. The other thing is the employee must have a note from the pharmacist stating the employee's name, who is doing the delivery, the place of the delivery, and also the name and the quantity of the medication to be delivered, and a copy of the subsection 56 exemption. And I think we'll link it into this slide so that you guys have a copy of it, or we'll provide a copy after the talk. And the reason being is that, so if anything happens to that pharmacy employee, for example, if they're out there doing a delivery and they get stopped, for example, by the police officer, then those documentation will support them as to why they are carrying controlled drugs. Okay, so previously, when the delivery of controlled drugs by a pharmacy employee was implemented, our college excluded oat. It had to be delivered by the pharmacist. But like I just said, as of earlier this week, the college amended PPP 71, which is the professional policy for delivery of oat, to allow non-pharmacies to deliver oat. So this is a temporary authorization again, which is great because I know there has been a real significant increased demand for oat delivery services. So hopefully this change will really help with the challenges that some of my pharmacy colleagues are facing out there. Couple of points. Pharmacists are allowed to authorize a regulated health professional to deliver oat if they have the scope and competence to assess the patient and witness the ingestion of the oat where appropriate. So like your nurse colleagues can do that. The second thing is pharmacists, using their professional judgment, can also authorize pharmacy employees to deliver oat to a patient, but this is the very last resort. This authorization should be reserved for exceptional circumstances where it's absolutely not possible for a pharmacist or another regulated health professional to deliver that medication. So bearing in mind, if you have a pharmacy staff, a non-pharmacy who is delivering that, really important that they are comfortable providing that service. So it means you, the pharmacist, must educate the pharmacy employee and make sure they are appropriately trained when providing the dose. So it means including they confirm the patient identity when they actually do the delivery, that they have the knowledge and competence to provide the witness ingestion if applicable, which means that they know when it's safe and when it's not safe to provide the dose. So, you know, if the patient is very drowsy or has slurred speech or has any other symptoms of intoxication, you know, that employee knows what to do. The college did say, if possible, a pharmacist should assess the patient by phone or virtual means before the pharmacy employee releases the dose. And I know there are so many really fantastic techs and assistants out there, and that they really know their regular patients really well and have built great patient relationships. And so if they're doing the delivery and something just doesn't seem right, because they know their patients, make sure there's like a temporary policy in place so they know what to do in those sort of circumstances. And a couple of other points there. As I mentioned, the oat delivery, the dose must be directly delivered to the patient. It cannot be left with any other person. And also, in addition to the documents like outlined in the other professional practice policies, like the accountability log, the delivery log, every time a pharmacy employee does the delivery, they must document their name and their signature for each delivery and retain that document in the patient's record. Okay, I want to mention another amendment that was done to the delivery of oat professional practice policy, PPP 71. And this is a permanent amendment, which allows pharmacists to use their professional judgment and authorize delivery of oat to a patient if they feel it is safe, appropriate, and in the best interest of the patient. So this means that the prescriber no longer needs to authorize delivery of oat. As you can see from the example prescription on the right-hand side, they don't need to indicate authorization to deliver in that box. However, if a prescriber needs to prevent a delivery to a patient for various reasons, such as a patient is not clinically appropriate, or there's no safe housing, the prescriber then needs to specifically indicate do not deliver on the CPP form, or they can contact the pharmacy directly. So, I mean, during this time, for the health and safety of the public, the pharmacists and your members of team, just make sure before the delivery, just confirm with the patient if they're experiencing any COVID symptoms or self-isolating, and so you know how to maintain and practice that 2-meter physical distancing. And sort of a last comment here, I know it's a very challenging time. You know, these exemptions came out, the regulations are changing and things are moving fast. And so there are gray areas out there, okay? Things are moving fast. So just make sure as a pharmacist, you document very clearly your reasons, your rationale, your actions in the decision that you've made that may be in a gray area, and that it was based on providing continuity of patient care, and that it is for the best interest of the patient. Okay, Mona, I'll switch it back to you.
Okay, thanks, Anne. So in terms of OAT preparedness planning, again, the same thing, like similar to what Anne is saying, is really understand and know and tell your patients if they have symptoms or self-isolating due to symptoms, make sure they inform you. Talk to your patients about COVID-19, what are some of the signs and symptoms. Contingency plan, if they can't come in, or even if you can't as a team go visit, what are your contingency plans? Alternatives to promote social distances. In terms of understanding what telemedicine is, that's important because some people might not have access to phones. So what does that mean? Does that mean, is a phone adequate? Does the prescriber need to see the patient? Like, what does that mean? So that's part of our role to be part of that team. And again, if seems like there's a need for a longer duration of carries, have that conversation with the prescriber for your patients. Safe storage and take-home naloxone is important. If you go visit patients to do the deliveries, make sure you have naloxone kits available on you as well, just in case something happens on the route. And then inform the prescribers and patients about your delivery services, if there is a plan to do that, or if it's available, or what your capacity is in terms of your teams. And of course, in urban centers and different types of centers, there's a lot of outreach teams, and you can connect with the outreach teams to have further discussions and further support patients for sure. So guidance for pharmacists is really, like, we know this so well, like, keep on saying there's no need to stockpile any medications. And I think it's died down a little bit this week. We had a better week at the store even this week. Reassess layout of the pharmacy for workflow at the intake. What is there, space for lining up? Do you have a sign saying, X number of people coming in? The counseling area too. What does that look like? Look at your chairs. Are the chairs adequate in terms of being cleaned, in terms of everything to do with cleaning, of course. Look at your dispensary. Look at how your staff or your colleagues are walking around, because we need to also try and social distance as best as we can within our tight space. So when appropriate, of course, we went over this, consider the delivery of OAT medications. Again, safety and adequate staffing needs to be considered, especially if one of us goes sick, or are there backup plans? What if the whole pharmacy needs to be closed? What does that look like? Do we have a backup pharmacy that we can transfer certain things to ensure that there is continuity of care? And again, work with the prescribers, work with the outreach teams for any changes in the patient situation, or something's just not quite right with the scenario in worst case scenarios. So when possible, we have to be very specific for pharmacy hours and delivery options, because as you know, with OAT medications, people should be taking it roughly at the same time each day. It has to be stable, it has to be predictable, communicated clearly, including a time frame. For one of ours route, we actually say to them, if we do not, for some of the patients, if we do not get here by a certain time, something happened, and when we can call you, you call us. And usually what has happened in the past is something along the route happened and we had to call emergency services. So make a plan for that should something bad happen. Apartment versus a house, a lot of buzzers might not work in some of the social housing units, unfortunately. And again, what Anne said, we can offer emergency supply of prescription drugs in case something is wrong with that prescription, or something just happened, like maybe the prescriber, we couldn't fill it under a prescriber's name because it always happens usually on a weekend or something. Okay, so in terms of bulletins, like I said, we have the COVID-19 bulletin that comes out, and Amanda updates quite often on this, Amanda and team, and we send out this once in a while. So do get on our mailing list for that. And there's other guidance documents on alcohol use disorder if you're interested in learning about that, IOAT. There's patient materials you can actually access as well, because it's very confusing out there, especially since things are happening so fast. So that you know, we're giving a webinar now here for pharmacists, but we also have guidance documents that we speak to prescribers about, and these prescribers are nurse practitioners, they're GPs, they're specialists in the area too. So they do document patients' treatment plan in their medical record. They support using telemedicine or the phone right now. And they've been advised to give us time as pharmacy to adjust those doses, and then writing certain prescriptions to reduce clinic and pharmacy visits. They're well aware of the social distancing for sure. They do look at individual factors when prescribing longer duration of carry doses, but if you as a pharmacist notice that there's something not quite right about a situation, or the patient's asking for more help, then you can actually connect back with the prescriber as usual protocol and procedures that you do at your locations. And again, the other thing which is so important right now is longer carries might have an increase of overdose potentially for some individuals that aren't as stable. So you watch out for that. For example, one of our patients, we tried a weekly deliver. Didn't quite work out because she's a little bit forgetful right now, and then she potentially might have taken her dose twice in one day. So we're readjusting everything, and the prescriber is readjusting his plan as well with the scenario that's happening right now. Definitely naloxone kit counseling is so important, and make sure people have adequate supply of the naloxone kits too, and ensure that people know, don't use alone, and educate on not using alone. It could mean a phone call before they prep the use, and then a phone call afterwards to check that they are safe at home. Because with the COVID-19 situation, really it's about social distancing, but however, when you're using, you should not ever use alone. So there's a little bit of things that need to be put into place to ensure that people are not using alone. The guidance documents also for prescribers is we also teach them about KDN a little bit. Carry doses might be okay right now because temporarily there might be a need for social isolation. And some of the scripts that you might see is no sprinkling. It's simply because our hands can be contaminated too, right? And we want to protect those patients quite a lot because it will decrease the handling of the capsule by us, by our hands, or even if we glove up, we still have to ensure that our hands are clean, or our gloved hands are clean as well. So I'm going to go through the next 15 minutes or so with a few cases. So a patient is currently on methadone per Pharmanet, and then this script comes up. So never assume that there's multi-doctoring or if it's a fake prescription, because right now times have changed a bit in terms of looking at the pandemic use of safe supply in these crises. So it's really, really important to confirm both medications are used if it's not already written, and the prescribers have been educated on that. Perhaps you should write on there that you are aware that the patient is on methadone, and yes, please prescribe hydromorph at the same time. So the goal, of course, everybody has that basic right to self-isolate or maintain physical distance. Everybody has the right to avoid substance-related harms. So again, this is what I mentioned, reiterate on checking in with a buddy rather than using alone, safe storage in case others get into the supply. And you might want to discuss, like, how do you move to carries if needed? Let's say, for example, a patient comes in every day. all of a sudden there's some symptoms. What do they need to do? The script doesn't run out in another 2 weeks or so. So ensure and really tell your patients that things can be communicated back to the prescribers, and they do not need to worry. Things can be done on the phone by us or via fax. That way they know the process. This is a really important page at the college website to really bookmark, because things change so fast, even within the last few days. So on the bcpharmacist.org website, which is our College of Pharmacists of BC, generally what the team has done over in the communications department is that last little bit, it says COVID-19, so it pertains to COVID-19. If it says other things like OAT, it pertains to OAT. So review this page on an ongoing basis for sure. One of the common questions that I've gotten, and same with the colleges, and I think BCPHA as well, is pharmacy staff are concerned about transmission surrounding OAT and the accountability log or the duplicate form. So the question posted on the college website said, can we forgo the patient signature to maintain social distancing? So what's really important is that you're supposed to get all this done. It is mandated that we have to get the signatures, etc. But also remember, consistency is important for workflow, for your own staff or your own colleagues, and for your patients, because everything's in the same, is proceeded in the same manner, it's easier for your patients to understand. It's easier for workflow management too. So the answer is quite generic, where it's please take all precautions you can, including disinfection, restricting contact, etc. But if you are making procedural changes in the best interest of your patients, so this is a gray area, and your staff's health, ensure you document your temporary policy and that it's understood by all staff. So a lot of places have put this in their standard operating procedures book, because it is a little gray right now. But again, it's the best interest of your patients, because as we all know, some of our hands are quite dirty, and it is high touch points. However, that being said, is the colleges are reviewing, as well as the Ministry of Health, etc., because they continue to monitor what is going on, and things sometimes take a bit of time with what is going on right now in terms of regulation. But do monitor this site consistently and frequently. And if you do something that's deviating from normal practice, document, as what Anne said, always document. Case 2, patient delivery considerations. So other considerations that you should be doing is plan out routes for timing of doses and limit traveling. So limit traveling means like you're not traveling from one area of town to another area of town, because what if you are potentially tracking more germs around? But you need to also ensure that you are properly hand washing, etc. Also include extra time if the elevators aren't working, because sometimes elevators don't work, or the stairway emergency doors don't work in a certain building. Or if there's a limitation, as you are all aware, there's a limit of people in the elevators or stairs too. So things will take time, especially in a building that houses a lot of people. You might have to also assess other prescription needs, because it's not just OAT that you should be assessing. Assess all those other needs. Are there heart pills that need to be looked at? Mood medications. Are people on time taking these mood medications? Because there's a lot of stressors happening right now with patients. And of course, always confirm if you, your staff, or even the patient is experiencing symptoms of COVID-19 or are self-isolating prior to delivering those medications. Physical distancing, think about your visitations, think about even your own place of work. How do you physical distance? So the next slide actually shows some pictures here. So an example I have, physical distancing on elevators is kind of hard. And some of the smaller units, it's really one little tiny elevator space for a person to go up on. So on the top left there, that's an example of a table that somebody always leaves out for us. She just leaves it out. We put her medications there. We gently knock, and then she comes, and then we assess the situation with her, making sure she's okay, etc. Then she drinks her dose, and then then that's the 2-meter distance that we have. Another one in the middle there, somebody left a stool for us, and then another person on the lower right over there, when we open her door, there's a table exactly right at her doorway. So using gloves or not using gloves, if you use gloves, you still have to hand wash in between, you know, putting on a new set of gloves for people. Wearing a mask or not, it really depends on the situation for the PPE. For some of our patients, if they have oxygen and they're using nebulizers at home, because that is the case for some of our patients, then definitely we would be masking up. And of course, if you're servicing individuals that are COVID-19 positive, there are other things that you need to be considering in terms of PPE and in terms of your capacity as a pharmacy. And also your capacity in terms of your staff being knowledgeable in the area of assessment. So case 3 and 4 are cases that we present to prescribers in terms of writing prescriptions. So case 3 is a very general case where we do see a lot of patients that are coming in for this. So 70-year-old woman who's well known to the GP's clinic is on methadone 120 milligrams for 10 years, so quite stable. However, she still continues to use IM fentanyl and is really concerned about her risk of COVID-19 because she's older, and then she also has other comorbid diseases. So after discussion with the prescriber, she would like MS on 250 milligrams daily. And generally speaking, when you're talking to patients in a clinic setting, they know what they're using, they know exactly what is going on, and they generally do tell the prescriber the truth in terms of the usage. So the prescriber prescribes this as a daily dispense. She is offered twice weekly dispense of her medications as well, but she would like to continue daily. And this is because sometimes, as you know, she wants an interaction with the pharmacist because you've known her for quite a long time. And it's also a check-in for her to make sure things are good. So case 4, this can happen, and this is what you also need to be planning for. A 45-year-old woman under the GP's care is waiting for a result of a COVID-19 test in isolation at a Housing First project. She does use a mixture of medications. So crystal meth, 1 gram per day, Ativan 1 milligram at night, and also a 0.5 use of fentanyl per day IV, depending on what she's using or depends on her supply chain. So in terms of titration, when a prescriber looks at this, we're really looking at a SROM titration. So day 1 could be 300 milligrams, day 2, 400 milligrams, 500 and 600, because she isn't at care as of yet in terms of looking at the substance use disorder. And again, this is more prescription in the context of the pandemic right now, and this individual could be transitioned to more care in terms of her substance use disorders a bit later on. Dilaudid hydromorphone, 8 milligrams for 7 tablets per day might hold her. And then the dextrogen, really looking at a long-acting and a methylphenidate immediate release at a 10 milligrams twice a day. And the Ativan 1 milligram at bedtime would be very reasonable. So we would expect as a pharmacist to have the prescriber write down either, you know, they're aware that these are all being co-prescribed. And again, as a pharmacist, we would just connect in. For your prescribers in the area, they're just starting to do this a lot more, and you'll know which prescribers are prescribing these medications and just connect with them, because sometimes it's important to you know, have the same connections in terms of what is happening with the patients in the area. So I'll go to care plans in terms of the long term. In terms of long term, the prescribers and ourselves as pharmacists, we're really looking at the patients and also the substances that they're using. Shared decision making with the prescribers is really important with prescribers and patients. Nothing too abrupt to change up things, because drug supply out there is drying up right now. Functional changes is important on their end for the prescriber, but it's also important for our end as pharmacists, because if things seem to be a little bit different, we all know we all know those patients that things doesn't seem to be quite right, and we call the prescribers to help perhaps get a reconnection with the prescribers if needed. And then there are definitely different plans for different substances. Like I said, some of the benzo use right now with the pandemic prescribing, eventually there will be a relook at the patient's long-term care plans on what to do with the benzo use to ensure that there's no abrupt abruptness of stopping things or in terms of drug interactions. So I think I'll end with that for questions and discussion about some of the new guidelines. The very last slide, so that you know when these are sent out, there's resources available for you to click on to get more information should you need it.
Great, thanks, Mona. So if you would like to ask a question, we have about 5 minutes remaining. Please let us know in the chat function and we'll try to get to them. Any questions that we can't get to, we're going to be trying to compile an FAQ document and we'll recirculate with you. So go ahead and ask your questions in the chat. I am just reviewing. Mona, we'll kick it off by saying, you know, what does safer supply look like beyond COVID?
It's a good question. We don't know yet. Everything's in discussion. Hopefully, there'll be a relook at things for sure, because we've been looking at trying to get safer supply for a very long time now. There are studies that will be looked at. There will be intervention. When interventions are done, those kind of interventions will be looked at to see whether or not safer supply has helped as well.
Great. Another question here. Is there dosage equivalent to street stimulant to Ritalin?
Is there, sorry, I didn't quite hear.
Is there dosage equivalent from street stimulants to Ritalin?
Is there dosage equivalent from street stimulants to Ritalin? Again, it depends on the grade of that stimulant, because it's really hard to tell what's out there still. It's still a crappy supply out there. So symptom control, a few other things, check in with the prescriber. For you as a pharmacist, you know, talk with the prescriber and the patients as well, so that you can help the patients a little bit more in trying to get the right dose for them.
I have a question here, more of a clarification point, but Anne, if you don't mind just reconfirming, what can pharmacists do in terms of adapting or extending prescriptions?
Yeah, so just to confirm, pharmacists, when it comes to controlled drugs, narcotics and targeted substances, pharmacists cannot extend. That means they cannot renew, they cannot adapt the prescription at all. So you can't use any of the pharmacare intervention code. So yeah, pharmacists just cannot adapt prescriptions for those types of drugs. Like I said, our policy hasn't changed around that. And like I said before as well, I know there has been confusion with the word extend. Health Canada uses the word extend. And extend could mean renewal or refill. So here in BC, we just cannot renew a prescription as a prescriber ourselves when it comes to controlled drugs.
Thank you. What is our obligation to deliver if we feel our safety is at risk?
Your obligation is to look at your capacity of your work location. If it's not safe for you to deliver, you can actually transfer that prescription elsewhere. BCCSU in collaboration with BCPHA, we're actually gathering data on which pharmacies are able to offer delivery and at what capacity. So you can connect in with either BCCSU or BCPHA, and we can help you find a location that potentially can offer that delivery service.
Yeah, and just to add on, if you cannot deliver, it's recommended to make a referral to a pharmacy that is able to have that capacity rather than just leaving the patient with no solution, which would be the best practice is obviously to recommend.
Great. One final question here. It says, I've also heard that Ontario recommends brand named allotted versus generic. Do you have any thoughts or recommendation for what we should do here in BC?
Yeah, I can answer that. The brand name allotted is just a better product for people that are using the substances. The generic version has too much chalk in the generic brand.
Great, thank you so much, Guy. So we're gonna leave it there, folks. Thank you so much for joining us today. If you have any further questions, please let us know. Otherwise, check out those list of resources. And on behalf of the BC CSU and the BC Pharmacy Association, thanks so much for attending and take care.